Good evening, everyone, and welcome to tonight's webinar, Ovarian Reserve and Aging, Understanding Fertility Potential Over Time. My name is Irina MacArthur, and I'm Director of Patient Experience at Inception Fertility. And I'm so glad you're here with us tonight. Tonight, we are absolutely honored to be joined by Dr. Deborah Shaw from Advanced Fertility Center of Chicago. Dr. Shaw will guide us through an important and often misunderstood part of reproductive health, how ovarian reserve change over time, and what does it mean for your fertility journey. We'll open the floor for questions and answer at the end of the webinar, and you are welcome to submit questions in the Q&A box, or please raise your virtual hand and I will unmute you and you can ask your question live. Thank you once again for joining us tonight. And with that, I'm delighted to turn it over to Dr. Shaw. Dr. Shaw?
Change the slide, please.
Absolutely.
Good evening, I'm Dr. Deborah Shaw, and I'm going to start off by talking about introduction to ovarian reserve. Ovarian reserve basically means the number of eggs that remain in the ovary. Essentially, how many do you still have left, your supply that's still left? Women are born with all the eggs they will ever have, and we just lose them until the age of menopause. Next slide. The egg supply decreases over time. At birth, we're born with 1 × 10⁷ eggs. By puberty, it's down to about 400 to 500,000 that remain. The decline continues throughout our life, and by age 40, only about 25,000 eggs are still left, and at menopause, only a few hundred eggs remain. Age is the biggest factor we face in fertility. Both egg quantity and quality drop as we get older, and with the decline speeding up after mid-30s. Next slide. What is AMH? AMH basically is what we talk about, the anti-Mullerian hormone. It's a hormone that measures our ovarian reserve or egg quality. It helps to provide insight into fertility potential. How do we test it? It's just a simple blood draw, and you can take an AMH test at any time during your cycle. It doesn't really matter what day of the month it is because it stays stable month long. If you look at on the side of the slide, we talk about the normal AMH being about 1.5 to 4. If it's borderline, it's between 1 and 1.5, and low is below 1, 0 to 0.99. High is when we're over 4. I've seen somebody have an AMH as high as 32 in the past. Next slide, please. The AMH is currently the most useful indicator of ovarian reserve, and it estimates how many eggs you still have remaining. It does not guarantee just because you have a normal or a high AMH pregnancy. Age and egg quality will still impact our fertility, and a low AMH doesn't necessarily mean you can't get pregnant. It just takes a little longer and maybe harder and requires acting sooner when you find out the level. Next slide, please. FSH is another hormone that we test when we're testing for ovarian reserve. Again, it's a blood test, and it's usually obtained on day 2 to 3 of the cycle. At the start of the cycle, FSH should be at a baseline level, the lowest that it's going to be. We test estrogen a lot of times along with the FSH because we don't want it to be over 50. If it's over 50, it can also be associated with ovarian reserve compromise. Next slide, please. This is showing what normal FSH levels look like. Before puberty, during puberty, at the time of menstruation and menopause. Normal or low FSH on day 3 is what we're looking for. It's a good sign. It means the body doesn't have to shout at the ovaries to get an egg to develop. When a FSH is high on day 3, it's a red flag for low ovarian reserve. When the ovaries have fewer eggs or they're not responsive, the pituitary keeps raising the FSH level because it's perceiving that there's not enough estrogen there. And in an effort to try to get the ovaries to produce more estrogen, so you get a high level, suggesting the ovaries are really trying really hard to stimulate, but not functioning well. And that indicates a diminished egg supply. With our clinic, if the FSH is over 20, we will not let people go through IVF in most cases because they don't stimulate well to the FSH medications. Next slide, please. This is a key point. In a young woman, FSH is usually low. We look for it to be under 9, usually on day 3. And an elevated day 3 FSH, for example, in the low teens or higher, may mean a lower chance of success in conception with her own eggs. However, FSH can vary cycle to cycle, and it's considered alongside AMH and other tests to have a complete picture of what's going on. Next slide. The next thing we would look at is an antral follicle count. This is obtained by an ultrasound and by a 3-dimensional ultrasound in our clinic. It's an ultrasound test to visualize and count the small numbers of resting follicles. They're antral because they're resting, and they're about 2 to 9 millimeters in size. They look like a little fluid sac, and you can see a picture of it next to the uterus there. And in the ovaries, they contain an immature egg in most cases. A fertility specialist, or in our case, we have ultrasound people that actually perform the transvaginal ultrasound in 3 dimensions. At the beginning of the menstrual cycle, the probe allows us to see and count the number of small follicles that we see. Next slide, please. Why does antral follicle count matter, actually? The number of these follicles on ultrasound correlates with the number of eggs you have in reserve. So the more follicles, the more eggs remaining, and the fewer follicles, less eggs. If somebody has 15 total antral follicles, that's probably a fairly normal number for a younger woman, although I usually tell the patients that if they're in the age category up to 30, that they probably have about 25 antral follicles normally. Seeing only 2 or 3 is a very strong indicator of a low ovarian reserve. In the pictures, you can see the high antral follicle count. That is a very common picture seen with polycystic ovarian syndrome. It looks like the ovary has they call it a pearl string pattern with multiple follicles around the edge of the ovary. There's no rigid cutoff that this is the number of antral follicles that you have to have. Between 10 and 20, if somebody's in their late 30s, early 40s, 10 is a good number, 20 is a good number as people are younger. An antral follicle count on the lower side that's 5 to 7 is a sign of diminished ovarian reserve, just like the AMH level can be. An unusually high antral follicle count is very commonly seen in polycystic ovary. I've had a patient have 50 antral follicles on each side one time. These small follicles are visible. They correspond to a high egg count. But with PCOS, not all eggs are going to mature like they should. And many times the egg quality is not good. I've seen somebody get 60 eggs at time of retrieval and have only 2 embryos that develop from the 60 eggs because of the PCOS. Next slide, please. Antral follicle count, when you combine it with AMH level, gives a clearer picture of what's going on with the ovarian reserve. It can also help predict how you might respond to stimulation of the ovary in treatments with like IVF or IUI. The antral follicle count test itself is quick and safe. It's basically just the ultrasound scan of the ovaries. Next slide, please. Women's egg supply declines gradually with age and more rapidly as we hit the 30s. By age 35, you see a pretty noticeable drop off in most people at the number of eggs and quality. And by age 40, the reserve is much lower. Only a few % of the birth egg supply still remains. Next slide. In addition to having fewer eggs, older eggs are more likely to have chromosome abnormalities. As age increases, chromosome abnormalities increase. It becomes harder to get pregnant and the risk of miscarriage goes up. For example, by age 40, about 60 to 70% of a woman's eggs are going to be chromosomally abnormal. In younger women, you'll have a higher proportion of them that are normal. But I usually tell the patients that the risk of chromosome abnormalities in your 20s is about 1 in 4,000. When you hit 35, it becomes 1 in 250. At 40, it's about 1 in 145, 1 in 30. So as you can see, as we age, we have much more higher numbers of chromosomally abnormal eggs. Next slide, please. Aging is natural, and so is a decline in fertility potential. It doesn't mean that you're not going to be able to have a healthy baby in the late 30s or 40s, but it's going to be more challenging in most people. It's important to use your ovarian reserve information in context. Age plus test results together give you a fuller picture of what the fertility window is showing you. Next slide, please. Interpreting the ovarian reserve results. If we talk about low ovarian reserve, we're talking diminished egg supply for your age. For example, a low AMH, a high FSH, and or a low antral follicle count is what you see in a low ovarian reserve. Even in somebody who's 20 or 30, that can be seen. This suggests you have fewer eggs remaining than what would be expected normally. It may be harder to get pregnant as time goes on, and you might respond less robustly to any fertility medications. However, low reserve doesn't mean zero chance. Many women with low reserve still conceive, sometimes requiring assistance. It does mean that one should consider sooner action, though. They shouldn't sit back and say, oh, I'll wait 6 months. Normally, if somebody is 35 or over, we recommend they don't go past 6 months. They seek care with a fertility specialist as soon as possible if they haven't gotten pregnant. Next slide, please. Normal ovarian reserve means that your AMH, your FSH, and your moderate antral follicle count is in the expected range for your age. This is reassuring to the patient. It says, okay, I have an average egg quantity. A normal reserve generally correlates with typical fertility potential. But if you're older and normal for your age is going to be lower as far as numbers of normal antral follicles as well. Normal reserve means you likely have a reasonable window of fertility left, but age becomes a key factor in success. And when we continue with our family building plans, we have to be mindful that fertility will decline over time. Next slide, please. High ovarian reserve. Some people will get a very high AMH level. As I said, I had somebody at 32 once. Normally high is over 4. And if the antral follicle count you're looking at is over 100 and their FSH is low, this is seen in younger women, sometimes like donor egg patients or those with polycystic ovaries. The high reserve means usually there's plenty of eggs available. On the face, it's positive for fertility and for IVF because they'll get decent numbers when you retrieve, but it doesn't guarantee fertility. For instance, in PCOS, a lot of those patients have more trouble getting pregnant, even though they have lots of eggs because they do not ovulate regularly and they have insulin resistance and other medical problems that go along with the polycystic ovarian syndrome. One consideration with high reserve is the risk of ovarian hyperstimulation. If somebody's doing IVF and I see somebody having 50 antral follicles on each side, we're going to start with a very much lower medication dose. If I have to go up during the stimulation, we'll do that. But the high reserve is generally a good thing to watch because if they end up overstimulating, they're going to look like they're halfway through a pregnancy. They're going to have lots of fluid in their abdomen and may require hospitalization and removal of some of that fluid because of an over response. Next slide, please. Ovarian reserve is about your egg quantity. It's not the quality per se. So these labels, low, normal, and high, need to be interpreted in context. A young woman with a low reserve might still have good quality eggs and conceive, whereas an older woman with a normal reserve might still face quality issues. Use these results to guide planning with your physician and next steps in your consultation with your doctor. Next slide, please. Fertility planning steps. The biggest thing I try to tell patients when I have friends or whoever come up and ask me questions is don't wait too long. Time is critical when egg supply is limited. For couples already trying, we shorten the time frame if they're over 35 to you should consult a specialist within 6 months of trying. Next slide, please. One thing that can be done to try to protect your eggs is called egg or embryo freezing. If you're not ready for getting pregnant yet, say you're 33, you haven't met Mr. Right, you're not ready to settle down, don't want to have a baby yet, but you want to safeguard your future options. Freezing the eggs is a common recommendation for low reserve or older patients. The process involves just taking hormone shots to stimulate the ovaries like we do with IVF in general to produce multiple eggs. The eggs are then retrieved under ultrasound guidance under anesthesia, and then they're frozen pretty much soon after they're retrieved. If you have a partner or you wish to, you can actually create and freeze embryos as another option. These are eggs that are fertilized for future transfer. Freezing locks the egg in at the age that you are now, rather than waiting 5 years. When you were 35, you froze your eggs. Now you're 40. Your success rates at 40 are going to be much lower if you were to use fresh eggs versus going back and using your frozen eggs that you froze when you were 32 to 35. And they can be invaluable for those that are have reserve dropping. Next slide, please. So our initial workup, this is just kind of an overview of the egg freezing timeline. The patient will come into the office 1 or 2 times, have an ultrasound and some blood testing. These are the AMH, the antral follicles, genetic carrier screening, including things like cystic fibrosis, sickle cell, Tay-Sachs, things that they screen for to make sure that you and your partner don't carry the same thing, or just letting you know what things you carry for future reference. The FDA mandates that we test for infectious diseases such as HIV, hepatitis B and C, gonorrhea, chlamydia, and syphilis. Some clinics will get other testing as well, but most of the time we just require an ultrasound and blood work initially, and making sure the patient has had a pap smear if they're over 40, a mammogram that's up to date, and a full exam to make sure that everything is normal when they're starting. Freezing the eggs after you complete your screening takes about 2 weeks. So it doesn't take long to get into the program to actually do the egg freezing. They start the injectable medications for about 10 to 12 days to stimulate the follicles, and it depends on the person. Some people respond quicker than others. Some patients are ready to trigger release of the eggs at 9 days. Some go up to 14 days. 4 to 5 visits for ultrasounds and blood work to see how you're responding occur. And then the egg retrieval is done once the follicles measure about 18 to 20 millimeters in size and around day 12 to 14. The eggs are frozen the same day they are collected. Once the lab is determined they've done what they call stripping the eggs, and they've determined that the eggs are mature or immature. And they will freeze EB2 eggs, which are fully mature eggs, and M1 eggs, which are slightly immature eggs, because those will often convert in the Petri dish to a mature egg. Next slide, please. This is just an overview of the IVF process. The follicles are stimulated using the injectable fertility meds called Follistim or Gonal-F. or menopause. The eggs are removed from the ovaries once they're mature. If you're doing full IVF, the eggs will be fertilized with the sperm in the petri dish once they've been cleaned off, and they are either injected directly into the egg if you do ICSI, or they're allowed to fertilize naturally in the petri dish with several sperm being there. The embryos that develop from the fertilization are grown in the laboratory, and then the embryos will be inserted into the uterus in what we call the transfer. It's usually done in most clinics now after the egg retrieval and the embryos being created. Many times the embryos are frozen because the success rates are higher with frozen transfer cycles than with fresh cycles. And once they're inserted just like doing an insemination, using a small catheter you come in with a slightly full bladder that helps to straighten your uterus, and then we transfer the embryos into the uterus. Next slide, please. Another option for people that have very low ovarian reserve or have undergone cycles that they've had very poor outcomes with no embryos that make it out to blastocyst stage, no embryos that are testing genetically normal, would be egg donor. This is an option when women's own eggs are either too few or not viable enough to achieve pregnancy. In this scenario, an egg from a donor who's usually in their 20s and is healthy is fertilized, and the resulting embryos then placed into the recipient's uterus. The donor eggs bypass the ovarian reserve issue entirely because you're essentially borrowing eggs. And the women in their 40s or those with very poor egg quality will consider this if they've sort of attempted everything possible to use their own eggs. It has an extremely high success rate because donor eggs are typically of good quality. The child that it would be born would be biologically related to the father if using the partner's sperm and the donor, but the recipient that carries the pregnancy and gives birth is the one who influences the environment tremendously. And the environment is very important to the child's growth and development. It's a wonderful option for many, though it's a personal decision, and some prefer to pursue all options with their own eggs first. Some never will come to the decision to do donor eggs. It depends on their partner themselves, and that's their choice. Next slide, please. You only need one good egg. Remember that even if your reserve is low, it takes one healthy egg and one sperm to make a baby. And many times, I had one patient one time who was basically stating she only had two embryos to transfer, and she was like complaining that she's not going to be successful. Of course, she ended up getting pregnant with twins. So it only takes one egg and one sperm to make a baby. Next slide, please. The one thing that's important to remember is the emotional well-being. Going through fertility treatments is very difficult for people. It's normal to feel anxious, discouraged when facing issues of fertility, when things aren't working. It's real important to seek support. Go to friends that have gone through, to support groups. There are many of them out there. Also counselors that we can refer you to in our clinics that have been working with fertility patients, helping to decrease the stress involved, and also increasing the success rates because of the lowering of the stress. Sometimes just talking to others in the same boat lightens the emotional load and can help, especially if that person was successful with what you're doing, many times can be very helpful to your emotional support. Next slide, please. We're going to ask for any questions, or if you have any specific answers that you would like to hear.
Perfect. Thank you, Dr. Shell. There's a lot of informative information you shared with us today. And yes, I do have a question. If my AMH is normal, but I've been trying for a year without success, what should I do next?
In that situation, depending on your age, I would recommend if it's been over a year that the person should seek help either by going to their OBGYN and getting some basic testing done, um, or going to a fertility specialist, depending on, how anxious they are and how quick they want this to happen. Um, and going through, a lot of times patients will just come through to have the testing done to kind of see what's going on. Many times we'll pick up 45% of the time we'll pick up a male factor issue in that situation. It may not be the woman that's the problem in that scenario. It may be a male factor, especially with primary infertility. So it's always good to seek help sooner rather than later.
Thank you. And I just want to remind to patients on call as well, if you would like to ask the question live, please raise your virtual hand and I'll unmute you so you can ask your question directly to Dr. Shell. But yes, you as well can drop it in Q&A box and I will read it for Dr. Shell to answer. So our next question is, my AMH is 0.6 and I'm 35. I was able to conceive 3 times in a row, 3 months in a row, but they end up chemical pregnancy at 5 weeks. What does it mean when conception works but not leading to embryo development?
Most commonly, the most common reason for that happening is that you're conceiving, but in most cases, 90% of the time, it's a genetic abnormality that's causing the losses. In that situation, if somebody's gotten pregnant 3 times like that, I would strongly recommend that they go in and they consider doing testing of their genetics and also testing if they go through IVF. I had somebody one time that had 7 miscarriages before she came in to see me. She was only 28 years old. And when she came in, everything tested negative that we tested. And I said, you really need to go through IVF and just test your embryos genetically, put back a normal genetic embryo, which she did. And the first time she got 12 eggs. Or 12 embryos, I'm sorry. And out of 12, only 2 were genetically normal when they were tested. This is at age 28. She transferred the embryos and got pregnant, had a normal baby with no loss. Second time, same thing, 15 embryos. 5 were normal out of 15. The first transfer did not get pregnant. Second transfer got pregnant with her daughter and had a baby. Everything went fine. She was fine after the 2 children, and she came back to see me for annual exams. And when I did her pap smear one time, we found out she was pregnant at age 40. And of course, unfortunately, she ended up with a miscarriage again. So obviously, there's something genetically going on because testing the genetics helped her to go ahead and have a normal pregnancy.
Thank you for that, Dr. Shell. Our next question is, I have a low AFC, but normal AMH. Which one is more accurate?
Well, it depends on how they did the antral follicle count. If the antral follicle count is low, but they didn't do a 3-dimensional ultrasound, it probably should be repeated on day 2 or 3. And because I have seen people show up with a higher antral follicle count when it's done that way. AMH in the study that I was reading recently is the thing that goes down most frequently, that's associated more commonly with problems. In this study, they were actually looking at endometriosis and the people going in and having surgery for endometriosis and dropping the surgeon taking out normal tissue while they're trying to get the endometriomas out and lowering the patient's AMH level significantly. And the antral follicle count also was lowered, but they actually saw more of an effect with the AMH being low than with the antral follicle count.
Okay. Very good. Thank you very much. I see a question. What is the general success rate is using previous frozen eggs?
It's normally depending a little bit on where it was frozen and all of that, but normally you're looking at somewhere around 50 to 60% if they were frozen when you were in your early 30s. It's pretty good in the ones that I've seen. but you need to have an adequate number of, the problem is sometimes people will freeze 4 eggs. Well, out of 4 eggs, they may not get 2 kids. I asked one time a physician, a bigwig at the meeting, a 37-year-old of mine who wanted to freeze eggs, how many should she have in order to have 2 children? He said 25. So basically, when we have a higher age, we need more eggs to freeze because many times they won't fertilize. There's about a 60 or 70% fertilization rate, and many of them may not make it out to blastocyst stage. So you want to have more than just 4 or 5. You'd like to have a higher number to start with. You don't need to thaw all of them. You can thaw whatever. With donor egg, we thaw 6 eggs at a time and fertilize those 6. And then they use the numbers that they get from the fertilized 6 eggs. We guarantee 2, but many times people will get more than that. But it just shows that even donor egg patients don't get all of the eggs to develop and to fertilize.
Thank you, Dr. Shell. The next question is, I have low AMH in brackets 10 and follicle count that's normal, 20 plus. I'm 31. How soon should I consider freezing eggs?
I would consider freezing them right away because you're not getting any younger. And if you're not potentially looking to get married or to get pregnant within a couple years, you should consider freezing because it does give you the option then to not have to worry about the ticking clock as they always talk about, which I hate, but it's important to have them as backup. I had somebody who was 40 who found Mr. Right. She came in, she had frozen eggs in New York at 31. She basically had fibroids in her uterus, which we took out of the inside of the uterus. And as soon as she was done, she's like, we're ready to go to IVF. And I said, no, you're not. You're going to head to New York and you're going to thaw your eggs and you're going to use those eggs because your success rate's going to be much higher using a 31 years old eggs versus a 40-year-old's eggs.
Great, thank you. Our next question is, I have 8-year-old daughter. My AMH is 4.8. I had ectopic pregnancy and my right fallopian tube was removed. I got pregnant, but had a miscarriage at 5 weeks. My endometrium thicken is 5 millimeters, and there is a problem. It seems like, or it's a question mark. Is IVF possible with this thickness?
Yes. Yes, but we would do things to try to thicken the lining of the endometrium because 5 is thin. We don't transfer usually into a lining that's over, unless it's 6 to 7 is what we usually look for. And I've found that many times, if the patient can do an IVF cycle and then do a natural transfer versus using hormone replacement, many times they do much better because their own lining is going to develop on its own, in most cases, better than us giving estrogen and progesterone. And besides, they only use progesterone vaginally, which most people hate the progesterone shots. So I've seen it work on one of my patients who had very low, never would grow the lining over like 4 or 5, even with an injectable fertility cycle where most people get a really thick lining. She would never grow it that high. The only time she grew it, believe it or not, was with the Clomid cycle, which is usually the opposite effect. Most Clomid thins usually, not thickens, but she would get an 8 millimeter with Clomid. So we did a modified natural cycle. We used her Clomid, and she got 7 to 8 millimeter thickness of her lining, and that's the only time she got pregnant.
It's incredible. Thank you for sharing the story. The next question is, I had endometriosis surgeries in June 2024 and June 2025. My first egg retrieval gained 6 eggs. What are your concerns with such aggressive endometriosis for uterus implantation success at the age of 40?
At age of 46 isn't bad as far as the number that you've gotten, but Once you have embryos created, I would definitely check genetically the embryos so that you know that you're transferring a genetically normal one. With endometriosis, I strongly recommend that people do treatment of the endometriosis medically, not surgically, prior to a transfer. We would use Depo-Lupron for 2 months. They take one shot, and 28 days later, they take another shot. And then at the third month, when they would normally have another shot, they go into sub-Q Lupron and go into the transfer cycle. It doesn't allow them to get a period, which the regular periods cause more, inflammation. We know that from the study in the endocrinology journal, which was very good, that endometriosis patients have about a 50% reduction in success because of the autoimmune effects of implantation. And when that happens, it's because the endometriosis is causing the loss of integrin, which was one of the molecules that is important to implantation. Also, the inflammation is higher. So when we treat with Lupron, it suppresses that. And then the patient goes into the cycle without getting a period, and they'll get a higher success rate. I've seen it many times happen when patients have gone to I had somebody go to 2 different places, make embryos, and then come to me when I was working in Wisconsin at the time and say, I want you to transfer my embryos from these other places. And I said, well, we're not going to do that until we treat the endometriosis with medically, which we did. And she got pregnant and had a baby. And then 9 months of having a baby suppresses endometriosis. She breastfed, so that suppressed endometriosis. And then when she stopped breastfeeding, she got pregnant on her own again. So, I mean, the suppression of the cycle helps tremendously with the implantation, improving the implantation.
Thank you, Dr. Shah. Our next question is, how do fibroids within the uterine wall affect fertility, and which kind of fibroids are the most risky for pregnancy?
Well, the fibroids that really are the only ones that really cause the problems predominantly are the ones that are in the uterine, inside the uterus itself, in the cavity, in the endometrium. Those are the ones that are, because of the, again, inflammation they cause, and they prevent implantation of an embryo. So those need to be removed. But when it comes to fibroids in the muscle, like on the top of the uterus or on the side of the uterus, normally we don't recommend. We used to, a lot of times when I was first in training, we would go right immediately remove the fibroids. But many times you can cause significant scarring to the lining of the uterus, which then they can't implant and they have problems. Normally, if the fibroid is not causing the patient any problems with their bladder, problems going to the bathroom with the bowel movements, or having pain, significant pain and abnormal bleeding to becoming anemic, we will usually recommend they get pregnant. And in that case, most patients do just fine. As long as I had somebody with a 14-centimeter fibroid make it through the whole pregnancy. We ended up taking it out later, but she had some pain during the early stages because of the fibroids. When they're big, I can outgrow their blood supply during pregnancy. And in that situation, the patient will get pain because of they become calcified in that type of situation.
Thank you, Dr. Shah. The next question is there any way to increase my ovarian reserve?
Unfortunately, there are some things we can do to improve the quality, but the quantity is pretty much determined genetically. And menopause is based on your genetics. And most people, if they look and say, okay, my mom went through menopause at 40, you're likely going to go through at the same age. And if that's the case, you definitely want to be having the children or freezing your eggs sooner, because 40, many times, they'll go into menopause with a high FSH, and there's nothing they can do other than use donor eggs at that point. It can be very frustrating, but it's important to know what happens in your family in that scenario.
Thank you. Dr. Shah, is there any lifestyle consideration patients need to be aware of so that ovarian reserve not decreasing? Can you speak about those moments, please?
One of the things that I tell patients, a lot of times in young life, people use the pill. And the problem is the pill can suppress the AMH levels. And a lot of times, if patients go off the pill, it will correct a little bit. So the levels will go up a bit. Um, but lifestyle things would be things like definitely if they're overweight significantly, loss of weight down to a more normal BMI increases pregnancy rates. Healthy eating, a Mediterranean type diet with lean meats, um, vegetables, fruits, nuts, grains, fish, those things that are very healthy without the fats. The fat is the biggest problem. Patients always think that diabetes is caused by sugar, but it's not. It's actually higher impact of diabetes is because of increased fat intake. In fact, they did a study where they took medical students and they fed them high quantities of sugar for a month. They ate cakes, pies, everything, and they checked their blood sugars and AMH levels, and none of them became diabetic. But when they did the same with the fats, they were starting to develop diabetes because of the high fat intake. So it's important to watch the diet, mild exercise, not Iron Men like my brother does. I mean, basically things like walking, swimming, things that you enjoy doing that you don't feel like it's a drudgery to do is good. Exercise is good to help also with fertility. Supplements, a small, certain amounts of supplements are helpful. CoQ10 is one that's been shown significantly in placebo-controlled studies to be beneficial. And in that study, the women took 200 milligrams 3 times a day, and the guys took 200 milligrams twice a day. And they did see improvement in the egg quality and the sperm quality with it. There are very few other things. There's a million supplements that they advertise, but very few of them actually show benefits when you do placebo-controlled studies. Vitamin D, vitamin C, CoQ10 pretty much. Myo-inositol or inositol for patients with PCOS has been shown to be beneficial too. But most of the stuff, I mean, I was at the American Fertility meeting in October, and we went to the conference on low responders. And basically, the guy said, all these people come in with 50 bottles of medications that they're taking. And he said, all of it should be thrown away. He said that they're doing all these antioxidants. And by doing so many antioxidants, they're causing deoxidant. They're having the opposite effect of what they want. He said, your best is to use something simple. CoQ10 is an antioxidant, but not so many of them. Many times they decrease the effectiveness of what you're trying to benefit. So,
Right. Thank you. Thank you very much. And I see there are a lot of questions right now being submitted, so we'll try to answer all of them. So the next question is, if your AMH is lower than 1, does it mean that I might get my menopause earlier than other ladies?
yes, it can mean that. And you can see the levels drop sometimes within 6 month period of time. I have somebody recently that went from 3 to 1.5 in 6 months, basically. So it's important to check them, if somebody's to check them on a fairly 6 months to a year basis to see where things are going. But yes, less than 1, people are more likely to go into menopause sooner. So they should take that into consideration when they're trying to get pregnant.
Okay. Thank you. The next question is, if you had LEEP, LEEP in the past, does it affect your embryo transfer? Or can it affect your
It can sometimes, but more likely LEEP can cause problems with what we call incompetent cervix in people. So what can happen is they get pregnant, everything's going fine, they hit 18 to 19 weeks, and they suddenly have quiet dilation of the cervix and they lose the pregnancy. So when somebody's doing a LEEP procedure for cervical cancer or precancer, what they should be doing is being cautious, not using a huge loop, you trying to take out only where the abnormality is and not going so deep into the tissue, just going so they get rid of the actual abnormal cells. With the transfer, sometimes it may cause a problem with scarring. If the leap has caused scarring, you can actually see trouble getting into the cavity sometimes. So sometimes I'll use a laminaria, which is a seaweed that's compacted to gradually overnight dilate the cervix to try to make it easier to get into the cervix in that situation.
Thank you. The next question is for FET transfer of genetically normal embryos with medicated cycle, what are the success rates of pregnancy and live birth at 40? In this case, what could be the reason of miscarriage occurred at 6 weeks or implantation didn't happen? Are there any additional testing or treatment medication you recommend?
If you're transferring genetically normal embryos in our clinic, the success rate is more dependent on the genetically normal embryo being transferred. So usually we'll get 60 to 75% success rate, even if somebody's over 40. If they have a genetically normal embryo, they should have similar success rates to younger women in that situation. But if they're having a loss, you see, I said 75%. There's still that 25% of things that are structural that can be wrong. They're not chromosomally abnormal, but say somebody has spina bifida, or the baby is born with a defect like cleft lip and palate, or something that is causing the loss. Nature's saying this isn't normal. We're going to not allow this embryo to implant, or we're going to end up with a miscarriage. So there are structural things. We don't ever get 100% because not all embryos are genetically normal. Mm-hmm. And the structural things there's 4% in the normal population of losses anyway.
Thank you very much, Dr. Shah. The next question is, I'm 45 years old. I undergone 2 consultations with the blood work, ultrasound, and genetic testing. Everything looks good and normal. But if I'm practically too old to freeze the eggs, so why to undergo the retrieval surgery to pair with sperm and make an embryo to reimplant? Why not just very carefully select my sperm donor and then cut straight to insemination?
That's an option, but if you're 45 years old in our clinic, at 46, patients cannot do IVF because their response is poor usually. And so we have a cutoff of, most clinics are even 45. The cutoff is 46 in our clinic at the time of their 46th birthday. They cannot do IVF. So, I mean, IVF has a much higher success rate if you're getting genetically normal embryos. At 45, your success rate with IUI is single digits, maybe 1% or less. And that's just because of the actual number of normal eggs that you're making and the sperm and egg combination. Even in somebody who's 25 or 30, their success rate with IUI at best is probably about 10 to 15%. So it's much lower success rates. Where with 45, if you really want a child, your best bet is to go to the thing that's the highest success rates, which is IVF in that situation.
Yeah, Dr. Shell. The next question is, I keep reading about AMH online and I'm now panicking. Should I actually be worried?
Should she actually be worried? Is that what she's
saying? That's right. That's correct.
Well, it depends. Has she ever had her AMH checked?
No, it most probably is just general, and now so many information coming from Instagram and
Well, the best
elsewhere.
thing to do is to actually, test. A lot of the clinics will offer a basic testing where you get your FSH, your estrogen, and your AMH checked, and the male gets a semen analysis checked. Those are the basic 4 things that we start with. And if those come back normal, you can relax a little bit if, um, but if they, if there's a problem, you're going to pick it up sooner if you do the testing basically. And then you're going to say, okay, now I better, buckle down and try to get pregnant now because my levels are showing issues, that are not going to be changeable, down the road.
Thank you. And I see another related to AMH question. Is there any way to increase your AMH?
Like I said, stopping the pill. There's a few things that you can get it to sometimes improve, a little bit, but you're not going to get it go from 0.1 up to 5 or something like that. It's not. You may improve it a few percentage points but it's not going to go up much. It usually goes down is the problem as we age, because age is the biggest factor.
Thank you. The next question is, I'm 38 years old and has low AMH of 0.02. I'm debating if I should do a PGTA, and is there still chance for me with IVF?
Um, so she's wanting to know if she should try to do PGT.
No, I think it's just, oh, yes, actually, you're correct. Um, I'll read the question one more time. I'm 38 years old and has low AMH of 0.02, and I'm debating if I should do PGTA and still will have a chance with IVF cycle.
I would definitely do IVF with PGT in that scenario because the AMH is, you're not going to improve that. And you want to do it at the time that you're realizing what's going on as quickly as possible. The advantage to living in Illinois is that we do have a law that requires the insurance companies to cover IVF and infertility, which is a benefit which isn't available in some states. So it does make it easier to make the decision to go to IVF sooner, which is in the best interest.
Mhm. Thank you. And for a CoQ10 follow-up question, you mentioned the supplement CoQ10. Uh, how long it would realistically take when you will see the results basically before you see any difference for CoQ10?
It's usually a couple months in most cases. If you can be on it for a couple months, I've seen a guy really have improvement in their sperm, over 2 or 3 months of being on it. It really helped him tremendously, and they got pregnant trying on their own because of he was on the CoQ10. So it definitely helps to improve the gametes themselves.
Thank you. The next question is, what is the recommendation after an embryo transfer about what to eat to get positive results?
Well, I don't think that eating is going to help that. At that point, you've put it in, just eating healthy overall is going to help with your pregnancy, though. The success rates are going to be based more on the embryo itself and the lining of the uterus. But it's really beneficial when you're pregnant to be careful with what you're eating. Eating healthy may prevent you from getting gestational diabetes, preeclampsia, high blood pressure in pregnancy. So you're eating for two, so to speak, but you're not eating the amount that you would eat for two people. It's really 1.5 or 1.25, that you're eating for. So you eat healthy, and make sure you get protein, not high fats. High fats are not good, and high carbohydrates are not good. We need carbohydrates, but you want the low glycemic index carbohydrates, things that are high in fiber, brown breads, brown rice,
Mhm.
pastas are better than the white as far as that's concerned.
Thank you, Dr. Shell. The next question is, could having an hormonal IUD deplete your AMH level on the blood test? I'm 36 and I have low normal AMH level, but I'm doing an egg freezing right now with a random start, keeping my IUD in place. Just wondering if removing it would increase the amount of follicles in the future if needed.
Yes, it would help. I mean, because if it's the hormonal IUD, it's just like you're giving yourself hormones with a pill. It's just being distributed in a different area. And yes, patients should, in a lot of cases, take it out. If they're just freezing eggs, a lot of times we don't make people take it out, but if there already is a low AMH levels showing up or starting to be low normal, I would probably, yes, consider taking that out and freezing eggs enough so that you have good quality ones to use when you're ready to use them.
And is there any time frame for patient to wait after the removal? Would you recommend a couple of months or you can
I'd
go?
say lots of times patients get pregnant within a month or two after taking the IUD out on their own sometimes.
Oh, wow. Okay, thank you. And I think we have time for a last question here. My friend is older than me and her AMH is higher. How is that even possible?
It's because of the genetics. I mean, each person has basic genetic makeup, and some people go through menopause at an early age. So the AMH is going to drop because it's based on your numbers of follicles. And if your mom went through menopause at 30, or had somebody once went through at 28, she ended up using her friend's eggs because she basically had nothing at 28. So, I mean, a lot of it is genetic. And if you know that that's part of what your family faces, that people go through menopause at an early age, um, you would want to at least try to freeze eggs sooner just to protect your eggs down the road.
Thank you. Much appreciated, Dr. Shell. There's a lot of questions we answered today, and you shared very insightful information. Thank you once again for your time. And for everyone who joined us a little bit later in the webinar, we also want to remind you, you will receive a copy of the webinar after today. And we conduct the webinars on a monthly basis, so please be on the lookout. Your clinics has quarterly webinars posted and available. And Dr. Shell, if anyone is interested in getting consultation with you or second opinion, what have you, can you please explain how is and what is the best way to get in touch with you? And
I think that we had a slide that actually has a QR code that they can scan. At least I saw that at the end of mine.
there you go. Perfect.
We're part of the Prelude Inception Network. We have 4 clinics that are located in one downtown Chicago, one in Gurnee, one is in Arlington Heights, and one is in Downers Grove. So, I mean, there's plenty of options if you're needing to seek an appointment or consult. You can scan the code and they'll give you information with regards to, and we'd love to see you and try to help you be the next one with the baby.
Thank you once again, Dr. Shell, for your time. And thank you, everybody, for joining us tonight. Thank you. Have a pleasant evening.